Everybody, we're just about to get started. So thank you for coming and welcome. My name is Zachary. I'm a librarian here at Northeast Harbor. And before we get started, I would like to share that the library is able to offer free programs like this year-round, thanks to the generosity of our donors and our community collaborators like Northern Light Health. And now's a good time to mention, please help yourself to some refreshments if you haven't already. Coming up next Wednesday, we have authors Roxanne Robinson and Christina Baker-Klein coming to the MDI High School Auditorium. And on Thursday here at the library, we have a lecture from the Mount Desert Island Historical Society. If you'd like to see more about the library's upcoming events, please do subscribe to our weekly email newsletter. There is a sign-up sheet on the table back near the door. Now, to introduce this evening's program, please welcome Dr. Clifford Singer, Chief of the Center of Geriatric Cognitive and Mental Health at Acadia Hospital.
Thank you, Zach, and thank you to the library for hosting us, and to the Northern Light Foundation for helping organize this. And thank you for coming. Our mission tonight is to introduce you to our programs, if you should ever need our resources, and including our education resources, which is what we hope to accomplish tonight. I'd like to start off by introducing members of the foundation. Sarah, would you raise your hand? And Nicole?
Hi, I'm Nicole Trainer. I'm the officer for Acadia Hospital.
Okay.
Thank you.
And Wendy?
I'm Wendy Lux. I'm with the foundation, Bangor.
And Mike Smith, the head of the foundation. Yeah. And then members of our team, Dr. Campbell will be saying a few words.
Good evening.
And then Kayleen is one of our nurse practitioners. Kathleen is next to Dr. Campbell, one of our nurse practitioners. Dr. Otis will be speaking. Dr. Hollnagel will be speaking. That was a reluctant wave.
Much more enthusiastic.
Okay, good. And Dr. Gareth Howell will be speaking with me later. Gareth is a professor at Jackson Lab. And now I'd like to introduce again Dr. Campbell to say a few words about Acadia Hospital and our program.
Thank you. Good evening, everyone.
Good evening.
Well, first I'd like to thank the Northeast Harbor Library for sponsoring this event this evening, a chance for us to share knowledge and learn about healthy brain aging. I'm John Campbell. I'm the Vice President and Senior Physician Executive at Northern Light Acadia Hospital. I don't know if you know about Northern Light Acadia Hospital. We're a 100-bed psychiatric hospital in Bangor. We're one of 2 private psychiatric hospitals in the state of Maine. We serve the entire state, and in addition to our large inpatient service for adults and children, we have a host of outpatient specialty programs. And tonight, you're going to learn a lot about the expertise that we have at our Center for Geriatric and Cognitive Mental Health. So this is a very unique program, and one that we're incredibly proud of. It has 3 components to it. It has the Mood and Memory Clinic. It has the Robert C. Strauss Neurocognitive Research Program, and it has the MAINAH, M-A-I-N-A-H, I believe Dr. Singer came up with this, research registry. So the Mood and Memory Clinic is the only clinic like this in the state of Maine, and it serves aging adults with mental health issues that occur at that phase of life, and also, the onset of progressive neurological conditions that can affect cognition and behavior and mobility. We are a vital resource for the state. As we are probably aware, our demographic in Maine, we are the oldest state in the country, and hence clinical issues like this are very prevalent, and it's just wonderful to have such a team of experts willing to address it. We look at Acadia Hospital at outreach. We like to touch everyone in Maine. And our most recent accomplishment that we're extremely proud of is, and you may have read about this, we have a partnership with the Aroostook Area Agency on Aging, where we're supporting a memory care center in Presque Isle. And we are able to do this because we can project our expertise everywhere in the state of Maine because we have a very large and effective telehealth platform. So we can bring this expertise to where people are, and it's obviously much more convenient to get this care in your own community without having to drive long distances and all of the logistics of that. And, you know, the risks of driving, not always simple across the calendar in the state of Maine. So the Robert Strauss Neurocog Research Program, this is the only active clinical site in Maine for research in Alzheimer's disease and related dementias. It has a national reputation thanks to the work that Dr. Singer, the foundational work Dr. Singer has done, and the clinical team that's carrying this even further. And this program exists thanks to the generosity of Camilla Cochran, and I do want to mention that. And we're eternally grateful for the confidence that she's placed in Acadia Hospital to offer a program such as this. The challenge that we have, like the challenges of all programs that are working with later life folks and these conditions, is that Medicare is the most common insurance, and Medicare reimbursement rates could never cover the costs of the expertise and the care and the technology that's really required to excel at providing this. So we are in need of philanthropic support in order to do this, and I think demonstrating the confidence that Camilla has placed in us, I think that you can see that I think we're a good investment, and that we can carry these things forward, and we can touch many lives in the state of Maine. So tonight we're going to learn about healthy brain aging. I don't think in the United States right now we're going to have better expertise than this in a single room with free access for questions and shared knowledge. And please reach out to me or to Dr. Singer or to Nicole from the foundation if you would like to learn more. So again, in closing, I want to thank you for coming today, and it just helps us advance our Acadia Hospital mission, which is to empower people to improve their lives. So I'll let Dr. Singer return to the podium here, and have a wonderful evening.
Thank you, John, but I cannot take credit for coming up with the acronym MENA. However, when Cindy Whitehead, one of our research nurses, came up with that, I instantly recognized it as the name. It's the Maine Initiative for Neurologic Aging and Health, MENA. I'd like to introduce Ed Darling, who has some poignant and kind words to say. Ed, would you come up, please?
Yes. I'm good, Cliff. I may not get through this all that well, but I'll try. My wife, Mary Ellen, and I first met in the seventh grade. We went through grammar school and high school together. Well, that's a stretch. My senior year in high school, my dad sent me away to boarding school. Yeah, he said it was my grades, and he didn't think I could get into college. but I really knew I was just paying too much attention to Mary Ellen. Mary Ellen and I were married in 1962, and the good Lord took care of us for 60 years, blessing us with 4 children, 6 grandchildren, and 4 1/3 great-grandkids. It was about 7 years ago, I began to notice that Mary Ellen was beginning to forget a few things. I shrugged it off. We were in our 70s. You know, we've been known to lose a step or two. But as time progressed, it became apparent that perhaps it was not just a simple forgetfulness, that she might need some expert help. So her PCP suggested we take her to Dr. Singer. We were familiar with Dr. Singer, so Mary Ellen was comfortable with the suggestion. He had treated other family members in years past, and I knew Cliff, as he is a good, loyal customer at our family business.
We drove one of your cars here tonight.
Dr. Singer is a man of reason and exceptional kindness. We knew that Mary Ellen were in the best hands of all times. Excuse me if I get a little emotional. Once we understood that issues were related to Alzheimer's, I distinctly remember a conversation that Dr. Singer had with Mary Ellen and I about her driving. His kind, compassionate rationale was to tell Mary Ellen that she was physically able to drive, but he was concerned that she might get into an area where she was unfamiliar with and she could not probably find her way home. More importantly, her reaction times weren't as good as they used to be, and she might have an accident and someone could get hurt. Mary Ellen stopped driving that day. No hesitation, no questions. She trusted Dr. Singer. Alzheimer's disease is an insidious disease that steals your loved one day at a time. Well, there have been no significant breakthrough cures. My recommendation would be that you seek professional help, because there are drugs or medications, as we would call them, that will help slow the progression. The most significant help that Dr. Singer gave us was that to our family. He helped us understand what Mary Ellen was going through and how we should deal with it. That's the most exceptional advice that I ever had. And my family and I are eternally grateful to Dr. Singer. Thank you.
Thank you, Ed.
A political announcement.
Not a dry eye in the house, Ed. Oh, Nancy, that's a hard act to follow, but I'd like to introduce Nancy Dawson. You willing?
I'll probably start crying too. But I look around this room and all the people here along the back wall have been such a great help to our family in understanding Alzheimer's and the progression and what's happening. And also I can say, as being a Mainer, bred, born, and raised right here, and I love this state. And all you, whether you're Mainers or whether you've come to Maine and you've realized what a special place it is and its people are, and what it offers each one of us in peace. And well, you all know the special place in your heart that it has for you, right? Yeah. So we're very lucky to have Acadia Hospital it's a resource for everybody in eastern, western, northern Maine. So when you have a loved one, whether it's a young one, a child, or a teenager, or an adult, or a senior, they're there to help you. And the moment, when did Acadia open?
1992.
How many years ago was that? I'm gonna let you do the math. How many?
32 years.
32 years ago, I can't believe it. But it was full from the day that it opened. There was such a need for mental health in our region, and it has filled the void. And it's, they just expanded. How many more beds did you put in?
50 pediatric beds.
50 pediatric beds, yeah, it's huge, it's huge. And I'm sure you're gonna hear from all these professionals, all the wonderful things that are happening as far as treatments and blind studies and therapies that are coming up, which is a bright light for senior health. And all I can say is sing the praises of all these people that are there to help us and support us. And so now, let's hear what's happening.
Thank you, Nancy. And now I'd like to introduce Dr. Justin Otis, who is a neuropsychiatrist we recruited from Wisconsin, moved here a year ago, and Dr. Caroline Hollnagel, who's a neuropsychologist in the Mood and Memory Clinic. And Caroline's been in Maine for about 8 years, maybe? Almost. And she joined our clinic a year and a half or so ago, almost 2. And I want them to come up and tell you a little bit about healthy brain aging and about our the spectrum of our clinical services.
Good evening, everyone. Thank you for joining us. It's a pleasure to be here. Dr. Hollnagel and I will speak a little bit about what we do and how that fits into the care that we provide for our community. So I think this was maybe inadvertently set up pretty well. I'm a neuropsychologist. She's a backwards. I'm a neuropsychiatrist and a neuropsychologist. I just made my point in that it's easy to get these things confused. That was intentional, we'll say that. So I'm a neuropsychiatrist. My training is in psychiatry and then a fellowship in behavioral neurology and neuropsychiatry. So I see people at all ages who have neurological conditions causing cognitive, emotional, behavioral changes. So that's things that were very, very common, like Alzheimer's disease and vascular dementia, to things that are less common, rare conditions. And we manage the whole person, the whole case. So we're managing cognitive symptoms, behavioral symptoms, and a lot of the other changes across these conditions. So my approach to all the environments that I've lived in has always been team-based. I think that's one of the reasons I've been brought here as experience in an interdisciplinary clinic and as well as an interdisciplinary care network. The state of Wisconsin, where I came from, has a really robust Alzheimer's disease clinic network run by the university, where satellite clinics all throughout the state have training and expertise in these conditions, and then get the training and education and support kind of by the mothership at the university. We're really hoping to build out a similar model here because it really takes a village. Care for these conditions requires family members and social workers and providers of all different expertise and the support of the community. People need to stay physically active and socially active, and it's so easy for our worlds to get quite small when we're dealing with one of these conditions. So we really want to expand our ability to provide that well-rounded care and bring in the community and other providers into a team-based clinic. So that's one of my goals over the next couple of years, is to build out those services. And each of the folks we have here are a crucial member of that team. And especially over this next year, as we have a grant to build some programs, I think that's our main goal. So more to come and looking out for some of these changes. So we're going to be really reaching out into the community, expanding our team and the scope. I think that'll bring a lot of resources for how do you age gracefully? How do you keep in mind health at all stages of life with the future in mind? So I think a lot of these changes will be helpful. So I'm happy to be here. Thank you for taking your time out to come speak with us, and happy to take any questions that come up. And I'll pass the microphone off to Dr. Hollnagel. Thank you.
So I am Caroline Nagel, and I'm a neuropsychologist. My job when you come to see me is to bring you into my office and first of all, find out everything I can about you, because part of me is a psychologist. I will interview you and learn everything. But then to test you, so you feel like you're in school. And people are usually afraid to come to my appointments because we're going to test your attention and your memory and your visual spatial function and your problem solving, everything the brain does. My job is basically to be a mechanic, lift up the hood and see how everything in the engine is working. Like see if there's any sort of pattern to the things that you say you're having trouble with, right? So I want to talk to you a little bit about healthy aging and how do you keep this healthy? Like what are the things you can do? And Martha Storant was literally a giant in the field of geriatrics and aging. She was a psychologist who trained me, was my dissertation chair, and her advice to me on the first day of talking to us about this is successful aging, get a Roth IRA, learn to golf, and take care of a plant, right? Take care of a plant. Take care of a plant. So for some of you, it may be too late for the Roth IRA if you haven't started it already, but the other two you can still do. But I want to talk to you a little bit. What are some predictors of longevity in general? What do you guys know, or what have you thought, or what do you suspect? What keeps you alive for a long time? Anybody?
Community.
Community. Okay, what else?
Genetics.
Yes, what else?
Faith.
Faith, good. What else? Exercise, good. Anything else?
Diet.
Diet, yes.
Sleep.
Sleep, excellent. Healthy relationships, and what else?
Learning new things.
Learning new things. Okay, good. You guys, I'm done now because you did it all for me. So things that help us age successfully and longevity predictors. So number one, we're starting from the bottom up. Clean air. Clean air is important, but these are low on the list. Hypertension medications. We all come with our original plumbing, right? So imagine if this were your house, you would take care of it. You don't pour bacon grease necessarily down the trap, so you shouldn't pour it so much into your own as well. Whether you're lean or overweight, again, a low predictor, so good news for those of you that are not fond of exercising. But the next one up there is exercise. That becomes a moderate predictor. Cardiac rehab, if you have problems with your heart, getting your flu vaccine, right? So when you see your doctor every year, get your flu shot every year. Stop boozing, stop smoking. And the top two, right? Close relationships and social integration. So those things that were mentioned, your community, your faith, relationships, all of those things, those are the best things you can do for yourself, right? Because they help you stay sharp, right? But they help with your mood, right? And your sense of connectedness. And the things that you need to take care of the most are your brain through things like puzzles, right? And games and hobbies, continuing education, pick up a class, learn Italian, go to Italy, right? Your body, exercise. And you can combine things that take care of your body and the next one, which is mood. So what's something that takes care of your body and your mood? Now, I spent 17 years in California, so that's a hint. What are Californians known for doing? There's one on every corner. Not that.
Yoga.
Yeah. Yoga, yes, yoga. So yoga takes care of your body. Some of the important things you don't think about with yoga or anything that with flexibility, balance training, because falls, right? Our reflexes are slower, you can fall. That's a good way to get a head injury. Please don't do it. We have enough ice in the winter to slide on. Work on your balance. So yeah, exercise, swimming, walking, anything that you enjoy, taking care of your mood. That's your community, that's your faith, that's doing those things that you enjoy, getting outdoors every day. Do I have any gardeners? 1, 2, 3. Okay, good. There are little things in the dirt, right? Someone who studies the microbiome. How many extra pounds do you carry in your body that are interlopers? 13 pounds. 13 pounds of extra bacteria and other things that help us with digestion. So someone who was studying this and had no interest in mental health discovered something that boosted our mood. And it's in the dirt, right? We breathe them in, apparently. So garden, that's why I said take care of a plant, right? So social relationships. What is it about social relationships that help people so much? Anybody? Trust, right? How many of you have a friend, somebody that you can tell anything to? Right? They know you, you could say it, you're not going to be judged, or if you make the mistake, they know how to separate that out, right? Those sorts of things are very important. In studies on aging, people who have somebody very close or have connectedness, you can have poverty, you can have health issues, but if you have a social network, right, that helps people do the best, the longest, right? So I'd encourage you all to work on developing it. Even the casual relationships, saying hello to the person at the checkout, saying hi to the person who's delivering your mail, right? Having a small conversation, all of those things count and they're very important. So make sure that you're working on those relationships, okay? I'll answer questions afterwards as well if you have any other questions, but I just want to review for you guys, right? Take care of your brain, right? Keep it busy. Take care of your body, including balance, right? Take care of your mood and take care of your social relationships. And if you get those 4 things together, you'll be in really good shape. Right? And I don't know who's speaking next.
We are.
Oh, come on up.
Thanks, you two. They'll be back up later for the question and answer period. And I just wanted to emphasize dancing, dancing has been shown to be neuroprotective almost more than any other activity, because think of all the things it combines. It combines exercise, socialization, relationships, balance, strength, and also because you're more likely to continue dancing than you are to go to the gym. So, yeah. And then hearing aids. Yeah, that's it, because that keeps you engaged and keeps information coming in. Gareth.
I feel like I should foxtrot on.
I'd like to introduce Gareth Howell. Dr. Howell is a professor at Jackson Lab. He got interested in Alzheimer's disease through the eye, and he'll explain why. But he's one of our nation's top scientists in Alzheimer's disease and a close friend and collaborator. And I wanted you all to meet him.
We've moved from collaborator to close friend, because that's what I've been feeling, and with socialization, it's good to hang out. Good to hang out with Cliff. So I'm a neurogeneticist. So I study the genetics of the neural systems in both the eye and the brain. I'll be brief, but start at the beginning. I was part of the group of people who sequenced the first ever human genome. My small portion of the human X chromosome was the bit that I did for my Ph.D. And that really got me interested in genes and where they lie on the genome, but more importantly, what goes wrong with a gene in order to cause a disease. Some of the very earliest diseases that I studied were actually X-linked mental retardation, which single change in a single gene causes this disease. And this was in Cambridge in the United Kingdom. I can't claim to be Maine born and bred, but I'm Maine for a while now, so maybe my son was born here, but I'm still not a local. My kids went to school just over there in Northeast Harbor. So I came to Maine, but primarily the Jackson Labs, because I got frustrated by not being able to do the research about why does a change in a gene cause a disease. And the Jackson Laboratory, for those who don't know, has been going almost 100 years. And it studies the genetics of all sorts of diseases, such as cancer, such as any neural disease, neurodegenerative disease, as well as healthy and sadly unhealthy aging. I came for 3 years, and I'm still here almost 20 years later. It's a hard place to leave. I hope that my kids, who now have 2 accents, they have an English accent and an American accent, which was weird when they first came home and their friends would come with them and they would be speaking American to them and then turn to me and speak English, and it sounded so wrong. And now they switch halfway. If they were here now and they looked at me, the first half of the sentence would be in this English accent, and then they would turn to you and speak in an American accent. So I'm thinking that cognitively that's an advantage, because knowing multiple languages, at least accents, might cope. So working at the Jackson Labs, obviously mice are at the heart of the research that we do, particularly here in Bar Harbor. There's another campus down in Connecticut. And these findings that we've been hearing about in human studies really get as far as correlations. So as a population, it's better to dance and it's better to eat healthily. What we can't do is identify in which individual is it better to dance or eat healthily. Sometimes the genetics is more powerful than any lifestyle choice. And so what we're able to do with mice is to complement those human studies by fixing some of those variables. So we're able to change the genetics and introduce the odd lifestyle choice. So in my research, we've done a lot with exercise. So we can exercise the mice, and the changes that we see in the brains of mice are actually very similar to the changes that you see overall in the human population. What we can do is try and identify what are the nuts and bolts, what's going on underneath the hood of a mouse that's exercised, for instance. And what we found, I won't go into all the details, is that if you exercise mice that carry genetic risk, for instance, Alzheimer's disease, exercise doesn't have the same changes that you see if you don't carry those genetic risks. We've got other experiments ongoing in terms of a healthy and an unhealthy diet, so a higher fat diet, but we can control it so we can really understand other particular aspects of a diet. Is it refined sugar, or is it high fat? But then equally, in my research, I then get stuck because I don't want to cure diseases in mice. I want to take my findings and move them closer to the clinic. So this is where this kind of a human-mouse translation relationship really works the best. And enter initially Cliff and the Acadia Hospital in general. We're in Down East Maine. We don't have large medical schools to interact with on a daily basis. We have collaborators both nationally and internationally. But it's so much more powerful to have close collaborations, people that we can go to, both from let's understand the disease more. So I've been to visit Cliff, and some of my trainees have been to visit Cliff, really just to say, what is it like to live with Alzheimer's disease? How can we be more helpful from a research perspective? And so it's motivational for us to study these things in the mice, and then to turn to Cliff and his team to better understand how our experiments may be more applicable, more relevant back at Jack's. So that's kind of the personal, the one-on-one research, if you like. Where Cliff and I, and this may be where Cliff comes back up and takes over for a bit, is that it's noticeable that the state of Maine struggles to build really strong consortia so that we can tackle this together. You mentioned this is a village, and that's totally it. If you look at where the key centers are that study this disease around the state of Maine, they're dotted around and they're quite small. They're not as large as some of those centers that might be in Boston or Philadelphia or places like that. And so in order to truly ensure that both Maine makes the contribution to the research and to the development of new therapies, but more importantly, that individuals in Maine get access to the latest and greatest findings, including therapies, we have to come together as a Maine-wide community in order to tackle this disease. And so this is where Cliff and I have really been hanging out a lot as part of the Maine CDC effort to both the Healthy Brain Initiative and also the Maine State Plan for Alzheimer's Disease. We chair the Research and Resource Subcommittee. And I feel like we're the bad guys that sit at the back a little bit and mess around, have some fun, but we've actually been highlighted as the most advanced subcommittee on this because of the way in which we've already made some of these movements towards a consortium in the state of Maine. We had a meeting just this week with scientists down in Portland, and so we're really ready now to grasp the nettle and make a big difference. Cliff can talk about where we are with therapies. We're a little bit like where we were with cancer 15, 20 years ago. We have the beginnings of a therapy. You may see these anti-amyloid therapies clearing amyloid from the brain. They're not great, but they're a start. And there are so many other drugs and medications being tested. But even though we want to do better, maybe in the next 5 to 10 years, we won't be talking about one therapy, we'll be talking about multiple therapies. And so I think we really are at a new frontier in Alzheimer's disease, both in treatments, but also in predictions using biomarkers, blood-based biomarkers. And I'll end where I started, which is the eye. One of the things that I'm really passionate about is we can test blood quite easily, but we can also image our eyes quite. Hands up if you have an eye exam regularly, maybe every year. Keep your hand up if you have a brain exam every year. So what we're really interested in is the eye has a portion of the brain outside the skull. It's called the retina. It's neural tissue. It's built the same way as the brain is built. And you can look at it so much more easily and so much with low risk. And so some of the early changes we're seeing in our research is that some of the changes, particularly to the blood vessels in the eye, are similar to those changes in the brain. And so what we really want to try and push forward is test the blood, because that's really important, but also try and think about the retinal exam as a way of identifying those who may be more at risk of Alzheimer's and related dementias. You're going to come back? Yeah.
Thank you, Gareth. So I was recruited here to Maine to start the Mood and Memory Clinic 14 years ago. And I had always integrated research with my clinical work. But here I was starting this new clinic on my own, didn't know anybody. And it felt like I wasn't at a major academic medical center where I had always worked at a university or a medical school with a lot of research going on, a lot of research support. And Eastern Maine Medical Center actually has a clinical research center, and got introduced to those people early on. And together we started a clinical research program. Well, one day about 10 years ago, we were at the state capitol for Alzheimer's. There's actually an Alzheimer's Day at the state capitol. And the Jack's team was there, and we had the Acadia little research table was set up there. And I didn't really want to approach Jackson Lab because they wouldn't have any interest in what we were doing. They were doing real science. But they came over and they were like really interested in what we were doing. It seemed like they were really open to and looking for local collaborators. And over that period of time, we have worked or collaborated on a number of things, trying to figure out how we can do the kind of research here in Maine that will attract scientists and dementia specialists and clinicians who want to come where there's research infrastructure and activity going on, so they don't feel like they're coming to some backwater and have to start from scratch. And so that's what we've been working on. And now with the new monoclonal antibody, the IV infusions, which can clear amyloid from the brain, as Gareth alluded to, this is the start of precision medicine, where we have to make biomarker specific diagnoses of this disease to confirm the underlying pathology. We have to look at the genetics. The field is rapidly advancing. Now, Alzheimer's disease is more complicated than just amyloid. Removing amyloid from the brain is something that we can do now, but that doesn't cure the disease. There's other elements that other factors that have to be addressed, other pathologic processes. So it's a complicated process, but we are working on putting together the kind of collaborations And that's the strength of Maine. We don't have a big academic medical center. People have to go to Boston to get that. And some extent, Maine Health has some of that, but not in Alzheimer's disease. We're actually the strength in Maine in the Alzheimer's sphere, and we're close neighbors, we're good collaborators, and collaboration is one strength that Maine has. And so we're putting together these teams to develop the infrastructure that we now need to employ precision medicine for Alzheimer's disease and other dementias, but also the kind of infrastructure that will attract scientists and dementia specialists who need and want that kind of collaboration. Dr. Otis mentioned Wisconsin as a model, and that is a model for us to look at. So we've got a lot of work to do, but we're off to a good start. And again, main strength is in the collegiality that we have. When I first got here, people had to go to Boston to participate in a clinical trial, and they don't have to do that anymore. Now with the expertise we have, also people don't have to go to Boston, get second opinions or first opinions. Some of them still do, but they soon realize they don't have to do that because we have it here, and that's our hope. We also want to create the infrastructure necessary to attract people who can then bring the federal grants and leverage what is a pretty exciting time in science of brain aging to do the kind of research here that can benefit Mainers and can also take advantage of funding opportunities so we can build more infrastructure to help, not only help patients, but help their families as well. We can't do it on just clinical income alone. It doesn't cover it. So we have to build the programs with clinical trials and research dollars as well as philanthropy. That's the four legs of the stool that can support these programs. So we're working on it. We want to let you know that. Now what I want to do is turn it over to you guys to ask questions and invite everybody else up. Kayleen, Kathleen, John, Justin, Caroline, Gareth. Sarah, do you want to come up and answer questions?
Some questions about, let's see, talent acquisition, patient experience, or philanthropy. Those are my answers.
Okay, well,
Yeah.
stay where you are for now. Okay, Nancy.
Can you tell us a little bit about the infusion therapy, when did it start, and is it the Lafayette Center? And just tell us a little bit about it.
Oh, yeah, thanks for asking. So the FDA conditionally approved the first monoclonal antibody that attacks beta amyloid plaque in the brain 2 years ago. It was an extremely controversial decision because the data didn't really support approval very well, and a lot of people on the advisory committee resigned, but families were so desperate for treatment that there was a lot of pressure. Also, advocacy groups like the Alzheimer's Association wanted this drug available. So they approved it. Not many people used it, though. Last summer of 2023, FDA approved through a normal process a drug called lecanemab, or Leqembi. This is a much more effective drug, and we got it through our formulary committee, and we started using it recently. We had to set up, it's a difficult process because you have to monitor people very carefully for the potential side effects of these medications. And you also have to join a national consortium or registry. But we are using this drug. It has to be infused twice a month. And we're it can be done at the Cancer Center, Infusion Center. We're also using a place called Local Infusion, which is like a medical spa. It's on Broadway in Bangor. Yeah, isn't it nice?
Really nice.
Yeah, yeah. And so you sit there for an hour, you get this IV infusion, and it stimulates the immune system to clear beta amyloid plaque from the brain, and it does it very effectively, but you have to monitor safety very, very closely.
So that's 1 hour a week.
1 hour every 2 weeks.
Every 2 weeks.
For, we don't know how long, probably about 18 months. We have data going out 18 months to show that it significantly slows progression of the disease. But we have to only use it in select people who have certain genetics, who have at an earlier stage of the disease. So that's our conversation that we have to have. And so I think you're in that window, not you. Yeah. So we're doing it. Now, just one more follow-up. The FDA just approved last week donanemab, a second antibody, which is only once a month infusion.
What's the name of that again, please?
Donanemab, that's the generic name.
Yes.
Yeah. It's so new, I can't think of. No, donanemab, but it has what its commercial name is. They just came up with, it's an awful name. So it's once a month infusion, but the risk of side effects is a little more. So it has to be balanced against that. It may be slightly more effective, but we can't really say that because we haven't had a head-to-head comparison. But it is another option. And the point here is that this science is rapidly evolving. We're one of only 3 sites. There are 2 sites in Portland administering these treatments, and then we're doing it. You really have to go to specialists who know what they're doing with these drugs. But it is an exciting, exciting time. Yeah, yeah. There was another question back here before we get to you. Yes.
What's the difference between Alzheimer and dementia?
So dementia is a broad syndrome of cognitive decline. Alzheimer's disease is the most common cause in older adults. So it's a cause of dementia, but there are many, many causes of dementia. But it is, and most of them cause brain degeneration or neurodegeneration and are slowly progressive over time. Some are quickly progressive. But if a person is having memory or cognitive issues, they really need to see someone who is specially trained to understand how to diagnose Alzheimer's disease and to distinguish it from the dozens of other conditions that can cause cognitive problems. Not all of which are treatable, not all of which are progressive, but one does need to have a skilled person diagnosing this. Now, we can't, in our region, we can't see everybody with memory problems and cognitive issues. At one point, we had a 2-year-long wait list. And Susan Collins contacted me and said, what can I do? And I came up with an idea that, and she got it through the congressional spending. So we're gonna have a program this coming year that will help primary care doctors. And Dr. Otis alluded to this. We're trying to help people around the state diagnose these conditions and set up appropriate treatment plans. We'll still be available to guide them through the process, but we can't see everybody, so we have to help other people diagnose this.
You know, the one thing about Susan Collins, I'm not sure it was her mother or her father had Alzheimer's.
Yeah.
Her father did, yeah. Yeah, yeah.
You know, you
Yeah.
just don't realize what it's
Yeah.
all about.
Yeah.
And so it really helps when you understand, you know, you have someone you love and you care about, a friend or a family member, and you realize how much we all need help.
Mhm.
Absolutely.
Her father had Alzheimer's disease, and she's really
She's been right there.
she's been an amazing advocate. And partly with her advocacy, the federal investment in Alzheimer's disease research has gone from $500 million a year to, I think, $4 or $5 billion a year, something like that, in just the last decade. It's been an amazing.
What are the figures? I mean, I know that it's huge. It's really.
Oh, the number of people with Alzheimer's.
Yeah.
There's about 6 million people in the country with Alzheimer's disease, over 30,000 in Maine, and of course, because of the aging of our population, it's rapid. The numbers are rapidly increasing. Plus, we have all the other causes that may be age-related or genetically determined.
So 30,000 in the state.
Yeah. Interestingly, our individual risk of getting Alzheimer's disease is actually declining a little bit because we're healthier than our parents were. We drink less and we smoke less. Yeah, yeah. On average. That's an important distinction. You had the next
I was just
question.
going to say, my son is a top scientist at Biogen in Cambridge, and his wife was I don't know how to pronounce that name.
Aducanumab is what Biogen did.
No, the other company that would put came up with that.
Oh, ASI?
Yeah, I
Yeah.
never can pronounce
Yeah,
that.
yeah, yeah.
So that was kind of neat,
Yeah.
you know, and I always get on the cutting edge of what's coming out and what's new. And
Yeah.
he said, Mom, they're gonna have a whole thing coming right up soon where you can have the infusion at home. Although that sounds kind of tricky.
Well, we're
because
testing,
look at her
we're
side
testing
effects.
not infusion at home, but subcutaneous antibodies. That's the next
Okay.
step.
Yeah.
Yeah, we're gonna do a study with a subcutaneous antibody. Yeah. It's getting a little more difficult to recruit people in the trials because we now have these treatments, and, you know, trials involve a placebo. But we rely on people who still want to contribute to the science to participate in the trials. Someone else take over. Ask some of these people questions.
I have a question that somebody else will answer.
Yeah.
Because, and it's almost certainly going to be you, Dr.
Singer.
Hollnagel.
Hollnagel, yes. I'm the only Hollnagel any of you will ever meet. So if you forget the name, just ask, that's fine.
So, and you sort of mentioned the alcohol and the diet and the exercise, but then Dr. standing there with the British accent, Howell,
Yeah.
said, you know, but a lot of it doesn't even matter if your genetics, right? Like sometimes, like you can give mice, you know, have them exercise, and if their genetics are predisposed to it, the exercise isn't going to make a difference. For those of us in the room who enjoy perhaps sometimes eating something we probably shouldn't eat, like not sticking fully to a Mediterranean diet, for those of us who might enjoy sort of a glass of wine or a beer, and I'm not talking keg stands, but like, you know, some social drinking, there's clearly been a lot of press of late about how that is going to be horrific for us. But then you read things that say, but when you look at the percentage horrific, it's actually really low, and the social benefit of having the glasses of wine and moving up at work because you're out having drinks with colleagues, and you know, like how do we make sense of all of this genetics and psychology?
It's a great question, and I wish that we were at the point where we could all just go into one place and have everything done, like all of our genetics and all of our health, and get the full body scans and just know everything, right? Unfortunately, we're not there, and if we ever get there, it'll be expensive, and insurance probably won't approve it. But, you know, it's the stuff that you all already know, like you do things in moderation, and you can choose your diet. The Mediterranean diet, right, is good for preventing cognitive decline, and it encourages you to have a glass of wine daily.
And how bad is it to have some hot dogs?
It's all a dose effect.
It is a dose effect. If you're having like 5 hot dogs every day, it's probably affecting more than just your brain. So, you know, yeah.
We were,
Right.
also there's a balance, you know, you have to balance it against the joy and so forth. So Aileen and I were with a patient the other day, and I turned to her and I said, and you can have all the ice cream you can have, you want. And Kayleen looked at me and said, Dr. Singer. I said, did I say the wrong thing?
But I guess with it, I'd also say, like, there is talk about people of a certain age should get brain scans so that you have like a base case, right? And there are these genetic workups. I forget who that, hunk of a celebrity is who got it and found out that he has the marker for Alzheimer's. And so he's out there talking about this. Like, what do you think about those? Either like a base case brain scan before something's wrong or, I promise I'm not really a worrier.
Okay.
My father passed away a year ago after a long battle with Alzheimer's and Lewy body. So
I'll
it's
tell you,
as I think about my future.
yeah.
Like, I wonder.
I'll tell you a little secret. I have been a normal control in studies that do MRIs since I was 22. So I've been watching my brain every few years as you get it for free because you're in a study.
And what do you think? Like,
my brain's fine so far.
Right, no.
But I thought of this, when I was in my 20s, I had the same questions you did, and I was like, how am I going to make sure? So, but the other thing is, I don't know about Maine, but also in California, when I was there, I needed to do an MRI, and so I just called around and said, what's your cash price? $600, they did a brain scan.
Right.
Pay for it. The other scans, those are more expensive, they're hard to get, and you do need a doctor.
Is that something you would recommend, that
So this is with the same wisdom with body scans. They said, look, if you do a full body scan, it can be helpful. However, we all have things wrong with us that are benign. And so it can end up causing a lot more anxiety than actually being helpful. So again, with what Dr. Singer was saying about balancing things, one thing against another, that's a consideration for people to make.
I think that's key, because even when there's 2 genes that are changed in the rarest form of Alzheimer's disease that almost nobody has. The most common genetic risk is the gene known as apolipoprotein E, which is what a lot of people get tested for. It raises your risk for late onset Alzheimer's disease. And that's not a gene for Alzheimer's or that causes Alzheimer's. The most common form of Alzheimer's disease, there is no single predictor. But if you get any test, you will be told you are going to get Alzheimer's disease. And so we have to be really careful as we know more and more about the disease, that if we find out some hot dogs are not going to cause Alzheimer's disease, if we cut out hot dogs...
But do I need to exercise if I have that gene?
Right, but then that's where the balance comes in. But knowing your ApoE status is probably the one thing that may encourage,
keep going.
So if we all knew whether we were carrying the risk change in ApoE, known as ApoE4, then we might begin to think differently. It's on the 23andMe test, if anyone knows about 23andMe. That's the only thing, and even if you have both copies of your ApoE gene or this ApoE4, your risk is raised, but it does not guarantee that you're going to get Alzheimer's or dementia. But only then might you then think, maybe I'll have hot dogs once a week and not twice a week. All of these things are at a population level. If we all encouraged everybody to exercise or everybody to eat slightly healthier, then the cases of Alzheimer's disease would go down, which is something we haven't talked about, which is if we find treatment for Alzheimer's disease, we can't afford to treat everybody. There's too many people, these are too expensive. So we still have to think about health. That's why healthy brain aging is so important, that we have to still think about prevention, and that's where environmental things like exercise and these kind of modifiable risk factors come.
I'm going to ask, sorry.
The spotlight's been shining pretty brightly on Parkinson's recently. And I'm just wondering if there's similarities or is there any cross-pollination between those 2 studies?
Between what? I'm sorry?
Parkinson's.
Oh, Parkinson's,
and
yeah.
Alzheimer's.
Yeah.
I would think that one could help the other.
Yeah, Justin, you want to take that? I think we can, and then you go first, and then I'll take that.
Yeah, so my clinic is, I think, much more robustly filled with folks with Parkinson's, Lewy body, other conditions with a movement disorder. That's my personal area of interest and expertise. These conditions, as I say to my patients, they like friends, right? So as the brain is aging, it's more vulnerable to neurodegeneration, to these proteins misfolding and propagating throughout the nervous system. And so if you look at well, we take an 85-year-old and someone has dementia, right? They've had that cognitive decline that's meant functional impairment. What do they have? And you do an autopsy, and the answer is, well, they have a lot of things in there. They have Alzheimer's disease, they have the pathology associated with Parkinson's disease, they have 6 different types of vascular disease, and then some others. And so really it's a whole systems perspective, right? Everything kind of matters, and all these variables interact. To dovetail it with the prior question, right? I get asked, well, how did I get Alzheimer's disease in clinic? Well, there's 40 different ways to get Alzheimer's disease. You look at the good studies on risk factors, and there's a very large number of them. And so how do we make an individual choice about, should I have that hot dog or should I have that drink? Well, the collective risk is what matters, right? Some have more weight than others, but if you have 30 out of 40 on that checklist, we've got to really start thinking about some changes. And you can have strengths much more in one area that may offset the risk associated with other areas. So, these conditions are much more common as we age. There's a lot of shared principles between Alzheimer's disease and Parkinson's disease in terms of how these diseases develop, risk factors for them. At the same time, they are different diseases. They start in different places in the body. They have a different pattern of spread. And so, and there are different proteins involved. The biology is much, much different. You'd never have one of these new Alzheimer's drugs have any impact on Parkinson's, right? So,
Where does Parkinson's start?
yeah, so that's a long conversation, but the bowels and the nose are the short answer to that. So the bowels, the stomach, and the nose, and those are sort of our starting entry points. But yeah, so those are I think that'll derail us for a little too long and not get the question answered. But
Alzheimer's is the brain, or does it start someplace else?
So all of these different diseases have different starting points within the nervous system as a whole, and they spread in different ways. Some of them along nerves, some of them within the brain directly, and so there's all different patterns. So we really, I think, to speak to what our team is building here is we need personalized medicine, kind of like cancer has these days. We are 15 years behind where cancer is, and that we need to know which diseases are there, how they get there, what are our risk factors, how is this impacting the individual, and tailor our treatments to that. And we're just on the forefront of making that happen. So
and we're the geriatric state, we're the state of the union, so we've got great fodder here.
So nowhere is it more important that we're doing this work.
I just wanted to jump back to the annual scan.
Good.
Because I know you're intrigued by that. Your brain will continue to shrink, lose volume with age. Different regions change at different rates. So if you do it, you're going to find out your brain is shrinking, and you're going to get real nervous. But it could be perfectly normal. So at the point where you realize it's not normal, you're already going to know, because you're already going to have symptoms, because you've had beta amyloid in your brain for years.
I guess what I encourage is to have like a baseline, right? Not to do it every year, but you do it at like 45 or 50, and then in your 75 or 80, when you have issues, you have something to compare it to. Is what I heard.
Then what are you gonna do about it?
Yeah, that's not.
Like, so you know, like, well, that's
hindsight.
It's not going to be helpful. It's just not sensitive enough or specific enough to be helpful to know, to give you a diagnosis. Where we're headed is blood tests, or in some conditions, other type of tests, even skin biopsies that will give us specific diagnoses. We can diagnose Alzheimer's disease now before you have symptoms with a blood test. That's a remarkable
So is there a point
development.
at which you recommend that people start thinking about that?
When we have the ability to do something about it when you don't have symptoms. Those studies are underway. In fact, we just got asked to participate in one of those studies today. So hopefully we'll soon have that kind of clinical trial that people can belong to who don't have symptoms, but might be able to find out if they have the earliest manifestations of Alzheimer's disease.
I also just say to everybody, thank you for all the work that you're doing.
Right.
I have a question about actually get an appointment for a person that is showing some symptoms, seems like it's out a year. And then it seems like you're already behind the curve if you're waiting that long to get some information. How do you handle that situation? You mentioned a new program with the local doctors. That would be interesting to know more about.
Yeah, so we're starting that in August. It'll take us a while to reach out to people. If you want to know our progress on that, or if you have someone you want to refer to our clinic, hate to say it, but it's a little bit about who you know, and now you know.
I do know.
I would
know her very well.
I would encourage you, if that is something that interests you, speak to your primary care physicians about that. Let them know that that's coming and that
Yeah.
you would be interested in them learning more about this and being, you know, more educated on this and feeling more confident in their ability to diagnose you earlier.
But that's exactly the motivation why these guys need to stay and they need to grow, is because of the wait list, and you need to attract.
A year.
We need to younger Cliff singers to the state of Maine in order that the next generation are here. And if they're going to come here, they're going to want to do clinically translational research. So we need patient registries, which to encourage that we need. This is the purpose in many ways of why they're standing here, is because there aren't as people like Cliff to see patients in the state of Maine.
So we were out 2 years. Now these two joined us, and Kathleen joined us. It was just Kayleen and me. We're out 2 years. But now we're down to 6 months?
3 months?
3 months? Yeah.
Yes.
Yeah. So we're getting there. But you know, it's still exploding. So far this year, we've gotten 680 referrals. 680 referrals just this year.
For just us to see.
Yeah.
And Claire, that's on cognitive symptoms.
Well, I would say most of them are cognitive symptoms. Yeah, you're right. Some of them are for depression or mood.
But imagine when you're at risk, you have a referral because of a blood-based biomarker. So that's coming next year.
Right, that's right.
600.
That's right.
With blood-based biomarkers is going to become, who knows, thousands, which is why the PCPs need to be better educated to make the first line decision.
That's right.
Or else we turn to Dr. Google.
Other questions, sir?
You can eat hot dogs, but don't ask them.
Yeah. You had a question, sir?
Yeah, I have a question. I'm not sure who it's for, but Dr. Singer spoke of some recent new treatments that will slow the progression of cognitive decline. Is there anything on the horizon that can reverse cognitive decline?
There's one study that has pilot data and it's on diet.
What?
There's one study that has only pilot data that seems to show reversal in symptoms, and it's on diet. It's out of the University of California.
It's on diet?
On diet, yes, diet.
Were hot dogs part of the control group?
What they did was, I wish I could have been in this study. They prepared meals. It was 6 months. Some people were on the waiting list, other people got the food, and they sent you your meals every single day for 6 months. All 3 meals, right? Think how much you save on groceries, but they prepared cooking, but they prepared them all, and they just got their pilot data now.
What are we talking about?
Olive oil and oatmeal?
No, it's the Dean Ornish diet, and it's the Dean Ornish, O-R-N-I-S-H, but he's very, very strict. It's a very strict diet. It gets rid of all of your favorite things.
There are also interventions, learning things, exercise interventions, social interventions that do show some improvement. Some of that improvement may be temporary and may just be related to enhanced mood. It's very hard to tease this apart. We know that intensive exercise can increase the volume of the hippocampus and increase some memory functions, but you're fighting a disease that's, fighting against that. So how long and how robust those changes are, it's going to take a lot more than just some of these other interventions or habits to it has to be very intensive dietary, social, or physical interventions to actually improve things. You know, the drugs we've been using for 20 years can improve things in some people and help people hold steady, just the oral medications. But they don't do anything for the underlying pathology. So we're a long way, I think, from having medical treatments that can actually build the brain back together. That's not out of the realm of possibility. First, we have to learn how to stop the disease, and then maybe we'll get somewhere where we can build it back together. Yeah.
Dr. Singer mentioned hippocampus. That's the part of the brain that facilitates long-term storage of your memories. And it's Latin for seahorse because it looks like a seahorse under a microscope.
Yeah.
Question in the back?
Yeah, we have a question from the Zoom audience.
Oh.
How well do the little brain games on your phone actually help in the prevention of neurocognitive decline?
The little what?
Brain games.
Oh, well, that's part of keeping your brain busy. It's one component. It's not the only, it wouldn't be my only tool that I would use, but it's a good thing to have, right?
Like Wordle.
I love
Wordle, yeah. I was poor today.
As my mother would say, couldn't hurt.
You also have to think about when you do it in the day. Screen time before bed disrupts sleep.
Right.
And sleep is by far the best thing to do at night. Second, but anyway.
Yeah, sleep, yes.
I was gonna say, it's great to reverse everything with the exercise and the humor and just being out volunteering and being engaged. Your quality of life is great. And that, you know, that's gonna set up all kinds of stuff in your brain. And you're gonna get the most out of whatever you've got. And maybe stop thinking about it and fretting about it, just kind of, yeah, you know what I mean?
Yeah, point well taken.
Yeah.
You mentioned the word volunteer.
Yeah.
I'm not an expert in this, but
It's huge.
one of the beneficial, if you want to try and have a healthy lifestyle, one of the things that you can do is volunteer, and that's been shown.
That's right, that's great.
Incredibly.
And humor is enormous. Just have that.
So you mentioned a little bit the lag time for getting appointments and things like that to possibly get a diagnosis. But I have a relative who lives, you know, across the border in a neighboring state, and they've finally gotten an appointment with, I don't know if it's a neuropsychologist or a neuropsychiatrist, but anyway, and so I'm wondering, you know, what's the general, I guess you might call it lag time from that first appointment with a specialist that, let's say, comes up with a diagnosis of mild cognitive decline consistent with aging. Maybe the family thinks, sure doesn't seem consistent with aging, but okay. You know, from when you get that kind of a diagnosis to when the specialist has done enough tests and feels comfortable to determine what type of dementia it is. That's
It's a good question.
I can take that one. So to dovetail on a term used earlier, cognitive decline, I think I'm always pushing why, right? Why are we having cognitive decline? What's the reason or reasons for that? Usually it's multiple, right? And that really dictates how you treat someone and what interventions, of which there may be many, you can bring in to help prevent further decline, if it's a progressive condition at all, right? There are many, many causes of cognitive impairment that are not necessarily progressive. And so there's things like treating someone's sleep apnea can significantly improve their memory. And so when we're asking the question, well, what's the risk of someone progressing? It really depends on why. And so in the absence of, you know, what's coming down the pipeline with biomarkers, blood tests for things like Alzheimer's, we make a diagnosis based on a conglomerate of a lot of different data. We have a neuropsychological assessment where someone's put through an extensive battery of testing to figure out, well, what is functioning well with memory and language and those things. You have imaging as a modality to physically look at the brain, or are there signs of damage, other signs of atrophy or shrinkage. You have the story, all of you that may come in and share what's going on. That's a piece of the evaluation as well. An extensive neurological exam, reflexes, movements, eyes especially. All of these things, when reviewed together, really should point towards the same cause or causes. And when we've arrived on that, it's answering that question. So what is it? Well, maybe in someone, it's a combination of their sleep apnea that's not treated, their hearing loss that's not treated, the poor sleep that they're getting because their cat keeps sleeping on their bed. And we have some early signs in the brain and on testing that also look like Alzheimer's disease. And several of those may be modifiable. Some of them may not, and so we need to personalize medicine in that sense and figure out for this individual, what are all the things that are causing the issue, and what are the risk factors for a developing condition that then we can mitigate with interventions. So the time frame, it's hard to say, right? It's very tailored to the individual, as it should be.
It's interesting to me hearing this, because when we think about what is the start of Alzheimer's disease, we go to cognitive changes. In the research space, to us, that's the last stage of Alzheimer's disease. When we talk about can we reverse the disease, we're asking, if the question was, can we reverse cognitive decline? The answer is probably no. But if we then take a step earlier in the disease, in my models, I look at the earliest imposition of amyloid. I'm looking at immune-like responses from the cells. The earliest stage is really the disconnection of nerve cells in the brain. Can we stop that disconnection? That is way before cognitive decline. So the aim here is both to treat and prevent the decline, which is where the current population of Alzheimer's sufferers are. But maybe the next population of Alzheimer's cases will not be because they've got cognitive decline, because they've got those earlier stages which are measured based on biomarkers in the blood. So that then what we're trying to stop, it's easier to stop the disease at that point because the brain is still somewhat intact. And so if you look at what's happening in the clinical trials, right at the front end, FDA approved are clearing amyloid in individuals who already show cognitive decline. So clear amyloid in individuals that don't have cognitive decline. Can we get better at that? But also then there are other aspects of brain health that we're trying to preserve by looking at immune-like cells, non-nerve cells that are doing things and beginning to do things better. So it'll be really interesting to monitor that over the next, let's hope it's not decades, but maybe in the next decade, where some of these treatments are making that, if you think of the circle of clinical trials, phase 1 at the outside, phase 3 and FDA approval right at the bullseye in the middle, all these things are on the outside of that kind of dartboard right now are not clearing the pathologies of the brain. They're trying to improve the behavior of the cells that are keeping the brain healthy, including the nerve cells themselves. So they're going beyond what we classically think of as Alzheimer's disease, which is amyloid and tau pathology and cognitive decline.
Another way of thinking about that, very important point, and it gets to your question. We want to eventually be able to increase the brain's resistance to Alzheimer's disease, that a person can have Alzheimer's pathology but never have cognitive decline.
So it's an effective cure.
It's an effective cure. If we can delay the onset of symptoms by 5 years, we can reduce the incidence or the prevalence of Alzheimer's disease by 50%. Yeah. Unfortunately, because people will die of other things. But you're preventing Alzheimer's disease. Yeah, you're slowing it up so that, and you're preserving life and function. There's two important concepts there. There's a difference between Alzheimer's pathology and Alzheimer's disease. I mean, it's a little bit semantic. I'm sort of in a group that says we should reserve the term Alzheimer's disease to people who are showing symptoms, as opposed to people who have Alzheimer's changes in their brain, Alzheimer's pathology, but it's not done enough damage yet for them to have symptoms. That's a very important group of people that we're interested in studying, because as Gareth says, if we can stop Alzheimer's disease at that stage before it's done damage, then we essentially have prevented cognitive decline. From that cause anyway, there's all these other things that might still happen.
The future, to dovetail on these points, our clinic is going to change because as we move into having more tests much earlier in life, the prevailing population we're going to be seeing in our clinic is going to be 40-year-olds, 45-year-olds, because in all of these different diseases, it's a 30-year process, and there's a lot happening 15 years upstream before anybody shows any symptoms. That being said, to take Parkinson's as the example, the first symptom of Parkinson's or Lewy body may be 30 years prior to the cognitive decline or prior to that tremor because of an unexplained loss of sense of smell or unexplained constipation or acting out dreams. There's studies that show you can find those things decades before the rest of the symptoms. And so those are the people we want to see in clinic, and they'll be the population in our clinic in the future, because then we can actually deal with it. So I think we have to change how we integrate care with others. At my last job, I made a deal with the sleep medicine doctors that if they found somebody who was acting out their dreams on a sleep study, they'd get an automatic referral to me. Didn't matter the age, they were 35, 40, and then we get to work on identifying risk factors. Do we see anything on exam or on testing yet? Do they have a family member with Parkinson's, and what can we do to get that ball rolling? That's going to be the future. I think once the cognitive decline or those more fulminant symptoms have started, it's much more difficult to make progress, and the studies have shown that so far.
Is the number on this particular invitation, the number to call to get an appointment?
Who's going to connect the dots?
There it is. Here's the man.
Dr. Singer,
No, that's
Here.
there's all kinds of information on that.
Oh, yeah, that's
Yeah, right back here.
Take the brain. Take the brain. Those blue brains. I
If
think
you
the
come to the
numbers.
back table before you leave,
Yeah.
the brain.
There are brochures and brain in the back. There's a brain. Yeah, stop drawing on it.
I didn't say
You want to
that.
say it?
Yeah, there you go.
That's what, that's got a phone number on it.
Well, that's a good way to close, everybody, handing out squishy brains. So thank you for coming tonight. I hope you learned something.